TPA is a biosynthetic form of human tissue plasminogen activator, commonly called a clotbuster. It's an IV drug that's considered a thrombolytic agent, and here in Canada it commonly goes by the brand names of Activase or Cathflow. TPA is commonly used in patients who have coronary artery thrombosis, myocardial infarction, pulmonary embolism, acute ischemic stroke, arterial thrombosis and embolism, and it's also used for clearing occluded IV catheters, normally central venous lines. For the purposes of this video, I'll be focusing on TPA being used for acute ischemic stroke. There are two different types of strokes, hemorrhagic and ischemic. In a hemorrhagic stroke, the blood vessels within the brain rupture or leak and cause bleeding within the brain and subsequent stroke symptoms. In an ischemic stroke, the blood vessels in the brain are blocked, which causes ischemia in the surrounding brain tissue. TPA is only used in cases of ischemic stroke. Once TPA is released into systemic circulation, it binds to the fibrin threads in a thrombus, or a clot. After it binds to the fibrin threads, it converts the plasminogen within the clot into plasmin, which allows the clot to be dissolved. Since TPA only converts plasminogen to plasmin when there's fibrin threads present, it has a local effect rather than a systemic one. In order for TPA to be effective, patients need to be treated with it within 3 hours of the onset of their stroke symptoms. In addition, they need to have a CT scan to rule out the possibility of a hemorrhagic stroke and to be sure that they're having an ischemic stroke. More important than the inclusion criteria are the exclusion criteria, which are things that mean that a patient can't have TPA treatment. So a few of them are any evidence of a brain bleed, any active bleeding of any kind anywhere in the body, a recent brain or spinal surgery, arteriovenous malformation or any aneurysms within the body, if they had a seizure at the onset of their stroke, if they have a brain tumor, if they have a blood glucose level of less than 2.7 millimoles per liter, a systolic blood pressure of greater than 185 millimeters of mercury, or a diastolic blood pressure of greater than 110 millimeters of mercury. Any of these factors mean that a patient cannot undergo TPA treatment. In addition to the information I've already discussed, there are some important nursing actions for patients who are undergoing treatment with TPA. Following treatment, the patient's blood pressure and neurologic function should be carefully assessed at the following intervals. For the first 2 hours, they should be assessed every 15 minutes. For the next 6 hours, they should be assessed every 30 minutes, and then they should be assessed every hour until 24 hours have elapsed following treatment. If the patient complains of any severe headache symptoms, they need to be reported to the physician right away as the patient requires a CT scan. If TPA is administered within 3 hours of the onset of the patient's stroke symptoms, they have a 42.5% chance of having good functional outcomes 3 months following treatment. If treatment is delayed and is administered within 3 to 4.5 hours of the onset of stroke symptoms, the risk for intracranial hemorrhage increases and the improvement of functional outcomes is inconsistent and uncertain. If TPA is administered after the 4.5-hour mark, the risk of intracranial hemorrhage increases exponentially, but the benefits don't actually increase. So in essence, if TPA is given within the 3-hour golden window, TPA can be extremely effective. Hopefully this video was helpful, and if you're looking for any more information on TPA, feel free to check out my references in the description box below.